You guys get to go through my little PowerPoint here initially, which was designed for sort of some basic information on telepresenting and telestroke in general. So coming from Virginia Mason, we always show the pyramid as we begin any of our presentations, and it just shows basically the pillars that we have and the fact that the patient's always on top. And so one of the benefits, of course, of telestroke is that the patient gets to see a specialist and gets additional sort of specialized care initially. So it really does put the patient on top and help with that. So learning objectives today is just to look at the terms telehealth, telemedicine, telestroke, and how they relate to things. The presenting patient site is going to be you guys, and the provider site will be wherever our stroke neurologist happens to be on his or her laptop. Describe some other terms, describe the role and responsibilities of the telepresenter, which will be you guys, and describe the two clinical telemedicine applications, which is live video, which is really what we're going to be talking about, and also talk a little bit about store and forward, which is sort of what we're doing with your CT scans. Describe steps for a live telemedicine video encounter consultation. Describe what happens in the telemedicine encounter before, during, and after the telemedicine consultation. Again, you guys will have some responsibility for that. Describe the telemedicine exam room setup and how to improve the encounter. Describe the use and setup of the video cart and how to troubleshoot the video cart if there's a problem. I'll just tell you the main troubleshooting thing right now is the telephone. You just go back to what we've been doing all along. But there are a few little tweaks that you can do in the interim. Describe the specific nursing tasks that may be required as the telestroke facilitator. So, it's the use of telecommunications to provide medical information and services. This has been around for a while. Health delivery consultations via the use of telecommunications, and we talk about telephone, which we've been using here already, fax, video conferencing, robotic technology, and store and forward. Some definitions. Telehealth includes the areas of health related to education, research, and administrative services in addition to clinical care. So Skyping your conferences or anything sort of like that is what that's talking about. Education, any kind of stroke conferences that you might get over the video thing, this is all a possibility. Telemedicine is clinical care through remote technologies and is focused on the doctor-patient or other provider-patient interactions. Telestroke is a specific sort of thing that we're talking about here, where we're just doing this sort of intervention for our stroke patients that come in. And store and forward is this, sending the EKG, sending the CT scan, sending the labs where you process those and then they go out to the provider. So, very brief history. I'm sorry that you guys have to go through all of this, but we'll go through it. EKG sent over newly installed telephone lines to a remote location for a read, 1906. So we're talking about this kind of idea has really been in the works for quite a long time, over for over 100 years now. 1924, the radio doctor starts out, and this is something that we still use today on ships. A lot of ships, cruise ships, have their own physicians, but for the smaller ships, when you call in, you can call into a source someplace and get a little advice as to what to do for an injured person. So television, first successful closed circuit to a hospital 100 miles away. That was sort of the birth of telemedicine. As the computers developed in the 1990s and became more proficient with their technology, it opened the door to better use of telemedicine. And in 1997, as Dr. Barcher talked about earlier, this became an issue at the government level to talk about and to try to get some ideas about. Unfortunately, during that time, there was no clear conclusions and there were no specific recommendations made. Low cost in the 2000s, we got the solid state devices, and that helped with both the cameras and obviously the processing. 2001 telemedicine report to Congress was updated with 5 key focus areas. Again, this was a study group that looked at telemedicine, and they said, oh yeah, we don't have great reimbursement for this, there's some legal issues, we need to work on safety and related issues, patient privacy, HIPAA, and all of those things. And then the telecommunications infrastructure was pretty minimal back then, and we really didn't have the ability to do all the things that we have the ability to today. And then in 2011, the Centers for Medicaid, CMS, published a final rule permitting Medicare participating hospitals to provide telemedicine services to their patients through written agreements with a distant site hospital or distant site telemedicine entity. And that's where we're at today. So you guys have contracted with us to provide telemedicine services. Reimbursement, fortunately, has come along a bit. So now we will be able to bill for some of these services. So hospitals at the originating site may now elect to credential and privilege telemedicine practitioners by relying on the credentialing and privileging. Now, I just threw this in because somehow during this process I got involved with credentialing. So first time for me, so working with Shannon and your group here and then my medical staff services support, we're working on getting the providers credentialed. So, and this was the radio news thing talking about back in 1924 about using this sort of technology to go ahead and examine patients. So, more informed decision making, one of the benefits, and enhanced quality of care. It's been shown to save lives through remote consultation, creates more efficient, convenient, potentially more cost-effective delivery of care. Patients don't have to drive, they don't have to go to a referral site somewhere where they can get their care right there. The possibilities for this are really quite huge, from in-home care to doctor care to all those sorts of places. So facilitates earlier, more accurate diagnosis and provides greater and faster access to a patient's medical history, including the risk of negative drug interactions or poor response to a course treatment. So, administrative and efficiency, well, we'll see about that. It allows rural residents to receive expert diagnosis and treatment from distant medical centers. Also what it does is it sets up this neurologist. If that patient's transferred, then they go, oh, I know you, I saw you on the camera, I saw you on the TV. They have some kind of warm handoff, a personal relationship already that's kind of set up. And that's really nice. Patients really like that, to go to another hospital miles away and actually see someone that they've already talked to. Timeliness of treatment, that's really what we're all about too. Decreases transfer rates while reducing medical costs through video technology. In the physician group, they talked about transferring everybody, whether that was what we were wanting, and that is not what we want at all. What we want is to offer that patient the best care at the time, and then to let you guys decide whether transfer is going to occur based on what you think and what the neurologist thinks would be the appropriate thing to do. So, supports real-time treatment by first responders through the use of wireless devices. Eric emailed me a while ago to say, hey, our EMS crews here want to get into having telemedicine, telestroke in the units, and that's being done in limited opportunities across the country, and so we will look into that as the future goes on. Again, this is a way that we might be able to get even earlier interventions and guide our EMS crews in a way that might be a little more efficient than the standard radio communication that we currently have. And enhances senior wellness and preventive care. What that's talking about is having a telecart perhaps on a mobile thing, and that can go into a patient's home where they're staying, and there can be a teleconference there between the primary care provider and that patient without having to bundle that patient up, perhaps put them in a wheelchair, get a ambulance, whatever you have to do to get that patient into the doctor's office. This is potentially a much more efficient way to do it. So why not just use a telephone, which is what we've been doing? Well, certainly the telephone's fine, but when you look at the studies, what they've shown is that they're less likely to get TPA. So there's an increase in the amount of patients that receive TPA, and this is a good thing. This is something that we want to have to offer our patients and to have everybody feel comfortable with. And also the correct treatment decision has been shown to be increased with the telestroke use. So what telephone only misses? Well, it doesn't get everything, but it can distinguish between aphasia and encephalopathy. Certainly the neurologist is trained and has seen a lot of these patients. Do mimics sometimes squeak through? Yes, they do. People get TPA that perhaps are not going to benefit by the TPA, but the studies have shown that even though they get the TPA, there's virtually no risk to having received that medication if you're, for lack of a better word, faking it from the neurologist. We had one patient that got TPA in our ED, and as soon as the bolus started to push in, she was miraculously better. So, as you know, TPA isn't quite that efficient. So, the chances were good that this patient was not really having a stroke, but it was very, very hard to tell initially until she did that. So, and we can distinguish most of the time between organic weakness and functional weakness. So, conversion disorder is hopefully ruled out. And again, this is going to offer your providers here the chance to, for lack of a better word, defer liability to some degree. The neurologist is going to offer recommendations based on their experience, and hopefully it'll make the providers feel much more comfortable with giving TPA. I know some of our physicians really do need to talk to the neurologist about giving TPA in certain settings. Stroke scale of 1 with a patient that had some aphasia, and the recommendation from the neurologist was to give TPA. Good health otherwise, well taken care of, middle-aged woman who would have suffered a great setback had she not been able to continue speaking. And this is one of the things that the neurologists look at: what impact is this stroke going to have on the patient's future? So even though her stroke scale was low, the patient ended up getting TPA after a discussion between the provider and the neurologist, and the patient did very well. So that's one of the good things. So just some examples. Now, I don't know if this is actually the woman's face, but if this is the doctor's face, gosh, I don't want to talk to this guy. How not to appear as a consultant. One of your jobs as helping with telestroke and acting as a telefacilitator is to advise the physician of how they appear on the camera. Are they too far back so their head's about the size of a quarter and nobody can really see them? Are they so close that they appear, as this guy does, just right there? So you're going to be, as the facilitator, sort of helping with the docs. Now the docs get nervous about this too, and so most of our docs have had quite a bit of experience with telemedicine and telestroke, some of them not so much. So although I think that you'll probably feel somewhat nervous, the doc is going to feel probably just as nervous on the other end and would appreciate any kind of advice that you would give to him or her about how they appear. So certified stroke centers treat about 10 to 20% of ischemic stroke patients with TPA, with 20% considered a current best practices. In reality, if you look at all stroke centers or all places that treat stroke, it's really about 4%. These are certified stroke centers, so they're more used to doing this. Most hospitals across the country are not on the TPA bandwagon, as it were, and so they aren't at that number of 20%. So when telestroke is used, TPA therapy increases tenfold. So telestroke decreases the door to needle times, decreases mortality, and produces better long-term patient outcomes. So the last group, the physician group that I talked to, I talked about a rather extended telestroke intervention. I think my point on that was that our providers really want to do the very best by the patients. They will spend the time to make the phone calls. They will go over, because they're getting consent from that patient. They want to know that both the patient and the family are very comfortable with receiving TPA, that if there's any questions, if we have to call to, I think it was a Waco or someplace where the other sister or daughter was, and they will do that. So they're really concerned that everybody's on board, feels good about getting the medication, and that they know all the risks and benefits that that has to offer. So let's go to before, during, and after telestroke. Now, practice. Know the equipment and how to troubleshoot. Stroke is a time sensitive. So one of the things that we're going to do, I think hopefully some this week, is just to do some practice runs with remote. I'll probably remote in from my office over in Seattle, and just to make sure that everybody feels comfortable looking at it and setting it up and doing that sort of thing. So some simple suggestions. You don't have to shout. You can just use a normal voice. Making sure everyone in the room can hear. The sound is going to come out of a central speaker on that machine, as Van is showing you. And it's good equipment. You guys have a really, really nice telecart. So both the audio and the video on this is going to be really superior. So, but you want to make sure that everybody can hear. Her husband may have a hearing issue or something like that. So as the event starts to unfold, you want to look at some things in the room and with the cart. So make sure everyone can hear. You may need to adjust the lighting. So we had the cart down in some of the rooms down below, both in the CCU area and in the ED. And sometimes it was so dark that you couldn't really see. So we just needed to turn on some additional lighting so it appears. You'll be able to see on the telecart both what the doctor sees, so you can kind of see what he's looking at, and what you're looking at as far as the provider goes. And of course, if they're, I don't know, in their car perhaps and remotely coming in on a laptop, you might need to suggest a different venue, or at least to turn on the dome light or something so everybody can see very well. Natural gestures when speaking. Smile and listen and look for the camera lens, not the monitor. That's a virtual impossibility, but you can try it. So when you're looking at the doctors, they'll be looking at their keyboard and kind of glancing up. So it's hard to get them to look right into their camera. Same issues sort of with Skyping with my daughter, who's busy trying to do a paper while I'm talking to her, head's down, and she doesn't appear very well. So you can kind of gently remind them to kind of look up or look at the camera a little bit more. Same with you. If you look right at the camera, it's a little easier for the doc to kind of figure out what's going on, although he'll be interested in the patient. So confirm the request for telestroke intervention. So we've talked about this with the providers. After that initial phone call, we'll go over the process a little bit more as we go on here. After that initial phone call, there's going to be a decision made between your provider and the neurologist as to whether they think that a telestroke intervention is warranted. If it's an ICH, if there's some other issues, some exclusion criteria that fall into place, they may opt not to do this. But if it's a kind of a classic stroke that looks like it might benefit Biolytic, then they're going to say that. So it's going to be up to your provider to sort of pass that on to you, to say, hey, we're going to do a telestroke in whatever room is going to go on. So decide who will be the telestroke facilitator. And I say in the room for 15 to 30 minutes. That doesn't mean you'll be doing the facilitation for that whole time. That means you're probably doing patient care while that's going on. But we talked about having the primary nurse be that person. Complete and confirm that all patient interventions have been completed. That's a standard sort of nursing care, the vital signs and the blood sugar and blood draws on an IV. And that can be done while some of that teleconferencing is going on. And check that the EMR is up in the room and briefly review the patient's chart. So kind of stuff. Bring the telecard into the room, proceed with setup, and that's why you're here today. So we can go over that. Plug in, turn it on, connect to the internet, which is just basically connecting to a data port, and those should all be up and live down in the ED. I don't know if they are now, but they will be shortly. And this is going to go live on the 20th, so that would be next Monday. So position and adjust the camera, frame the patient, adjust the lights, and adjust the audio. We talked briefly about that. There are some markers in the room that sort of says, kind of, why don't you put the telecart right sort of here. The remote doc will have control of that. He'll be able to control the camera and his looking at the patient. So you don't need to do anything with the camera. Fortunately, I don't see an on-off switch for the camera, so it's always going to be on. You click it on, so that'll be good. And if the cart's not quite right, well, you move it back a little bit, or you move it over here, or you do whatever you need to do so the consulting neurologist can see the patient better. And they're going to ask you to do that. Hey, I can't see the feet really well. Can you move the cart back? I know your rooms are small, and that may be a challenge for some stuff. And I've talked already about maybe using a little bend on that camera to get a little better position. But we'll see how it goes here initially and go from there. So The backup plan, we'll talk about also later, and that is troubleshooting. And if they have to go back to the telephone to complete this intervention, then they'll have to go back to the telephone. But there are a few things, some simple things you can do, like unplugging it, turning it off, plugging it back in, being the data port, and then having it come back on. So turning it back on. The reboot. What do you? I mean, that's what you have. You shut your computer off when you call IT, isn't that what they say? Shut it off, turn it back on, see if it works, and that's sort of the same thing here. So, telestroke consent. I don't know. In our hospital, when they sign the original form for care, they already have consent to this. And I think that's what you're doing here. So, and begin preparing the family and patient for the telestroke encounter. The last one we did, it was an older woman who was kind of like, I'm not sure what's going on here. And the daughter stepped in to say, oh, Mom, this is what I do at work every day. For heaven's sakes, don't worry about it. Just look at the camera, and the doc will go through it. And by the end of the intervention, most people are talking to the cart as if it were a provider. And that's really what we're looking for. We're looking for that presence in the room. And as you have interchange of conversation and vision, eventually the patient just sort of doesn't think about it as being something robotic or remote or unnatural. They just really are talking to a person, and that seems to be what has happened for us. So kind of know what's happening. So you can kind of tell them what you're going to do, what's going to happen. They're going to bring this card into the room. We're going to set it up. The neurology specialist is going to show up here and talk to you. So begin preparing the patient and family for the encounter. And obviously, if they have any questions, that's part of our job, is to try to answer those questions. And I always ask as many times as possible, yeah, are you guys comfortable? Do you have any questions? Do you want to do this? Telestroke is not, we don't want to force that on the people. We want to say, this is an option. You can actually talk to a stroke neurologist who can evaluate your condition here remotely and make recommendations. If they say, oh no, absolutely, I do not want to do that, fine. Then we're back to the way then you back off and you take the card out of the room and you go back to the telephone as it were before. But I've not had anybody do that yet. So during the event, continue to explain to the patient what they may expect and answer any questions. Now, our neurologists are sort of trained, or we hope they're trained, to interact with the patient. So if the patient has some, still has verbal capabilities and is able to do some stuff, the physician will talk to the patient as if they're in the room. We don't want them to look at the nurse and say, Rita, could you have the patient open their eyes? Well, it makes no sense to do that. And the physician should say, Mrs. Smith, can you open your eyes? Can you close your eyes? Can you do this? Can you do that? That's how we want this interaction to go. We want the physicians to look to you to help them, to be their hands, and also to maybe interpret some of the stuff if there is not, if you're doing touching the legs to see how their sensation is, or pinpricking, those sorts of things, they may need a little interpretation. How do you think that did she really feel that? And that sort of thing. And so that might fall into it. But really the physician should be explaining to the patient and to the family what's about to go on. So your role to act as a facilitator is to ensure patient safety. Obviously ABCs, or is it ACBs now, take priority. So this is not, if the patient deteriorates during a consultation, then you need to act on that, obviously, and to make sure the patient's safety is protected. So, and assist in the consultant in completing the exam. So, ED patient with stroke, so 16-year-old patient, the ED at 2200, has remote signs and symptoms at 2130. CT is negative for hemorrhage. Now, like here, I think that you have a lot of your EMS go right into the CT. We try to do the same thing if the CT is available in the ED, and try to get that done. We have a port in the CT room. We can actually do the whole teleconsultation from CT, although not everybody's comfortable doing that. So frequently they will go back to the room, and then it's completed in there. So the ED provider is considering TPA on IR intervention. The ED provider is requesting consultation with the neurologist on call. This will occur using Telestrokes, times 2035. So anyway, the facilitator. Now I put the ED provider. When this first came out and the ED providers had perhaps they were between patients or had a little bit of time, they were very excited about going into the room and talking to the neurologist on the camera. And they would actually take over the facilitator role and go through the whole exam. Do I know that's going to happen? I don't know. Maybe, maybe not. But now they don't do that anymore. Now they let the nurse take care of that. So we call a code stroke. We get the code stroke checklist, and I think we're going to go over that a little later. And the EMR is reviewed for any new results and any charting updates. Telecard is brought into the room and set up. This is my favorite cartoon. Today I got kicked out of the hospital. Apparently the sign "stroke patients here" meant something entirely different from what I thought. Anyway, now the consultant needs to log into the VM portal and connect with the telecard in your ED. So two things that happen. If they're at home, they may do this very quickly and have it all ready to go. So as what happened in our ED, the patient had not yet come back from CT, and the tech was walking by the room and looked in and came up to the charge nurse and said, you know, there's a guy on a TV in room 6 there, and he says he's waiting for something. That happens. The converse is that they're at a restaurant, they have their laptop, they're ready to go, but they're not that ready to go, so they need to find a quiet place, get into their little venue to set the thing up, log in, find out, connect with the Verizon, which is what we use to connect to our internet, and get that set up. So they may be there really early and not see the patient, or it may take a few minutes for them to get someplace and set this up. So be patient. Once the card's on, that's all you really need to do. They will log in when they can get to it right away. So be sure the telecard is working and the audio-video functions are adjusted. We'll talk about that. Continue to explain the process to the patient family, answer any questions, and obtain written consent from the patient. If you guys do that, I don't think that you do that. So.
Nope, when they sign in as a patient.
All right, so I want to show you a little demo of one of the things that we did in the ED, just to sort of give a little example here.
Hi, Dr. Yu, we're going to get you checked out, okay? Okay, so let's place her on the cardiac monitor, and I need an EKG. Can you squeeze my hands on both sides? Can you squeeze? Okay. She definitely has right-sided weakness. Let's do CT of the head, and let's get a point of care creatinine. CT's ready? Okay. Okay, so we're going to get a CT scan, okay? And I've talked to the neurologist. We're going to get some images of their brain, okay? She seems a little bit less responsive than when she first started. She was able to follow some basic commands. Is she able to look at you over to the left-hand side? Can you look over to the left? Can you look to the right? She's not really crossing the midline. Can you give me a smile? Okay, so she definitely has a left facial droop. 0 out of 5 strength on the right upper and lower extremity. Out of her stroke scale, but it's going to be pretty high, especially with the aphasia. No contraindication. She's still within the 4-hour time frame. Do we have any family member available to provide consent? Dr. Silova, Mr. Kennedy is here. Ms. Kennedy's husband, do you want to talk with him today? That would be very helpful. Okay, so Mr. Kennedy, why don't you stand right here? Hello, Mr. Kennedy. My name is Dr. Silova. I'm one of the neurologists here. We've just finished examining your wife and had a CAT scan, and it does look like she might have a blood clot in one of the arteries causing her to have a stroke. She's not moving the right side, and she's having a lot of trouble with her speech, probably trouble with her sensation also, which is an indication to consider giving her medication to try and decrease the symptoms of stroke and improve her prognosis in the long run. Now, this medication is something that is a strong blood thinner, so unfortunately it does also have a chance of causing some bleeding in the brain as a result. Again, with more stroke symptoms and a larger potential area of stroke, that chance is higher, although we do know that more patients benefit from this medicine than have any bad complications from it. From the standpoint of chances of bleeding, and Juliana, if you're still there, if we could take a look at the UCLA form in terms of TPA interventions, that would be very beneficial in regards to how many people benefit and what the risks of the blood-thinning medication and intervention is. If there were to be bleeding, that bleeding, can you hear me okay, sir?
Yes, I can hear you, doctor.
Okay. If that bleeding were to occur, it normally occurs in the area of brain that has already been injured or damaged by the stroke.
So the doctor here gave me this picture. What does this mean exactly?
So that picture, if you put it up toward the screen just a little bit, there you go. So yeah, you can put it toward yourself so you can see. So this is really looking at 100 people who experience a stroke, just in the situation that your wife is in.
Okay.
Of those 100 people, if all of them receive this medication to try and decrease the symptoms of the stroke long term, about 32 of them will have a better outcome. About 65 of them will have just about the same outcome as if they had not had the medicine. And only about 3 of those 100 patients will actually suffer a worse outcome. It's the best intervention that we have in regards to providing a better long-term benefit in a situation like this. But it is your choice if that's something that you would wish to pursue or not. Just to make sure she's still not moving that right-hand side, correct?
Yes, she's not. Can you move your arm? Yeah, she's still not moving her arm. Can you move your left arm? Okay, yeah. So her neuro exam has been stable. She's not improved.
Juliana, has the TPA been ordered?
Yes, TPA has been ordered. Pharmacy is here.
Oh, wonderful.
Can you see pharmacy? Can you see them?
Yes.
Okay. Right here. So her TPA is running.
So as you can see, it's always kind of busy, and they're going to deal with that. They being the stroke neurologist, are able to see in the room, so they can pan, tilt the camera as needed to talk to family, to see family, to do various and sundry things, to envision the whole patient. So that's proved to be very helpful. The role of the telestroke facilitator. So the facilitator will assist the consultant and the patient during the exam. So really the key thing is that you're going to be the hands of the neurologist. They are not expecting anything, well, I shouldn't say that, but their expectations of you will be kind of low. They will assume that you probably don't know NIH, that you don't know how to do a neurologic exam. That's what they've been told. We know differently than that, but they will sort of be able to design their exam with anybody in mind, with a layperson in mind. So they should be able to instruct you to do whatever it is they need you to do. And finger to nose, or grips, or sensation, drift, they will instruct you. And if you happen to know how to do those things, that will be great. But if you don't, they will be able to go through that process with you. So so you may help facilitate the interview and the NIH and the vital signs monitoring. Most of the neurologists will not go through the whole NIH to make a decision on whether this is a patient that needs TPA. They will look at some of the broader facets, do kind of an abbreviated NIH, and then say, okay, let's mix it up. We're gonna go for this. I need to talk to the provider, and we'll get this going. Then they may come back after the TPA has been bolused and the drip's running. The assumption is you will keep the patient here, unless there's some other thing, and then whether they're going to transfer or keep there, then the neurologist may choose to circle back and complete the NIH. Again, you may not want to facilitate or be able to facilitate with that. So, what was this? Okay. After the Telestroke consult, again, questions. Families always have some kind of questions, so if you can go ahead and circle back with them and review to make sure that all their questions are getting answered. Thank them for participating, and ask for any questions, confirm the plan. So once you know the plan, then you'll be able to pass it on to the family if the provider hasn't done that already, and make sure that they're clear that they're staying here, that they're being transferred, all the stuff that you would normally do. And then you and the neurologist need to say, okay, all your questions are answered, and questions of the family, the neurologist here, ask your questions, everybody happy, you're getting TPA, here's what we're doing, and then say, okay, we're going to disconnect now, so that everybody is comfortable at the end of it and say, bye-bye, nice meeting you, I'll see you at Virginia Mason or whatever in a day, and then you can disconnect. So, and then obviously if you haven't already gotten the TPA going, then you want to move on to getting your blood pressure control or whatever recommendations were made by the stroke neurologist and or your provider here, and some follow-up on the admission transfer process. As the telefacilitator, you'll be the primary troubleshooter. And so again, shut it down, unplug it from the wall, hope for the best, plug it in again, turn it on, and see if you can get the provider back. It's happened a couple of times to us where for some reason it just doesn't think it's going to play with you that day, and it has always come back the second time. We don't want to spend a long time doing that, but we want to spend just maybe a minute or two kind of redoing that whole thing and letting it reboot and see if it'll come back. If it fails, then you need to go to your provider and say, hey, it's not working, we need to reconnect with a neurologist. Backup plan is always the telephone, and report all technology-related problems to your IT staff, and then we will also get a report at our end if there's any problems. So. Again, back to the questions, provide the patient with the name and contact information of the consultant. If your doc's not done that, then you can say, you know, this guy's name was James Barcher, Dr. Barcher was your consultant, he's the guy you'll be contacting when you get in. He'll be the one that is going to be following you while you're in the hospital. Complete the encounter form, meaning basically do your charting. There's some specific telestroke charting that you guys have developed, and we'll talk about that. And when appropriate, have the patient family fill out a program evaluation. I talked to Linda a little bit about that, and we're looking at having a few days later to send out a little thing to either family or to the patient, depending on their disability, to say, how did it go? How did this make you feel? Did you have any questions or problems or those sorts of things? And to see if it was a positive experience for that patient. Debrief after the Telestroke event. We do that just with the docs to make sure that everybody was comfortable with it and everybody got their questions answered. Not frequently, I shouldn't say that, but on one occasion at least, the doctor was not convinced that he was wanting to give Telestroke or TPA to this Telestroke patient. So they had a private, out of the room conversation over the telephone, and the neurologist talked with our provider and went through some stuff, and eventually the patient did get TPA. But that was not something we wanted to have in the room with the provider, the ED provider, and the neurologist sort of discussing the pros and cons of this. So address the examination outcomes and any suggestion ideas for improving Telestroke events. Update obviously your EMR documentation, which I understand is going real well for you guys. And proceed with the stroke pathway, including admission transfer as needed. Any questions or comments or ideas? Again, we're gonna play with the machine. We're gonna play with your Telestroke notebook here, and we'll do some other stuff. So I'm really excited about it. I think this is going to be a wonderful, wonderful thing for you. I know that there are people that will be nervous, and our providers are very congenial, very happy. Some are a little more want to get it done, but they're all have been very good to our nursing staff, and I think as you do one or two even as drills, that you'll become very, very comfortable with this and not have any problem assisting the neurologist. Again, any questions or comments or thoughts?
Are there any forms that are like on the carts for the neurologist to reference for families?
There will be some
We'll go
forms,
over this.
yeah, in the thing, and they had, mostly what we would talk about is exclusion-inclusion criteria, and that's kind of a provider-to-provider discussion that goes on. But if there's something that comes up and the family's saying, hey, well, we want the clot buster, then we have the inclusion-exclusion criteria available to say, here are some issues that we see, and I think that your risk factors are going to be elevated because of these things. And the providers, the neurologists do talk about that. And then there's one other thing that they sort of look at and go over with the families. When I was in that little video holding that, we'll talk about that too. As again, sort of saying, here are the statistics that show what your risk factors are for both improvement, for no change, if they're having something more catastrophic occur. Yeah,
Do you have other hospitals that you set up Telestroke?
you're the first.
Oh, we're the first.
Yeah, you're the first that we.
And they just started this summer in their
Internally,
ED.
In your, okay.
What we did in preparation for bringing on the new spokes, you guys, is that we telestroke back into our own ED. So that was excellent practice for all of us, including our neurology providers. So after hours, they will telestroke into our ED and we'll complete the intervention at least 30 minutes sooner than we normally would, having them drive in from Bellevue or Kirkland or wherever they live to get there. So it's worked out really well as far as that goes. Evergreen Hospital on the east side would be our next spoke that we're looking at. All right. Thank you all.
On Monday and Tuesday, we had a RPIW event so that we could roll this out the right way. Always before, especially in the ER, stuff gets rolled out, we get told about it, and then we have to do it. So we decided that we were going to have a team of people that would roll this out. And we had ER nurses, Marcy from MedSurg CCU was there. We had all sorts of people. So we know that in 2013, 159 strokes came through the ER. And 6 to 8 were actually called from the floor. So that's why we wanted everybody involved. And we're also changing our process a little bit. So if you have your little, we'll go over this real quick. Yeah?
How many received TPA out of those?
I think we decided it was 5%, wasn't it? What was on 5% of those patients. Yeah, but that was all strokes that were that had a diagnosis of stroke, TIA, that type of thing. So I actually don't have the numbers for the less than 3 hours acute stroke that didn't have a hemorrhage, that type of thing. That number would be much higher as far as TPA. So anyway, if you have your little competency, we have changed our process a little bit, and we have tightened down exactly when do we call a stroke alert. And what we've decided is whether their patient comes through the ED or whether it's on the floor, if the symptoms are less than 6 hours, we're going to call overhead, including on the floors, a stroke alert.
Including middle of the night.
Including middle of the night, including 24/7, holidays, whatever. If it's less than 6 hours, we're going to call a stroke alert. If it's less than 3 hours, we'll go down the possible lytic, acute stroke possible lytic candidate, we're out. And if it's between 3 hours and 6 hours, we'll go down the non-lytic pathway. So the orders, both MedSurg CCU, the CPOE orders, and the ED orders are broken out into lytic candidate, non-lytic candidate. But if it's less than 6 hours, we are going to call the stroke alert. Okay? We have changed the process a little bit of who, it's not just going to be ancillary departments that will come to the stroke alert now. If the stroke is in the ED, one person from CCU will come down. And if the stroke is on the medical floors, then an ED nurse will grab the cart and head down to either CCU or MedSurg. And on the house supervisor form that they bring out twice a day, they are going to be actually delineating who is on the stroke team for the ED nurse and the inpatient nurse. Okay? And then that person, like if you're a CCU nurse and you come down, is going to be responsible of helping, but we're going to have a real job for you. And Susan's going to go over that in a second. The telestroke cart, that is going to live right next to the EKG machine in ER. It's going to be plugged in 24/7. It'll be down low enough so it doesn't hit the tracker board right by room 2 and 3. So it'll be in the ED hall, so everybody will know where it is, but it'll be plugged in and ready to go. Describing what locations the telestroke consult can be performed. It can be performed in any room in the hospital that has a data port. So like on MedSurg CCU, they are working on your data ports to put them on a special switch in the basement. But right now, if there were, on Monday, if there's a stroke in CCU or MedSurg, we're going to unplug your in-room computer, and we're going to plug in the machine if we decide to do telestroke. Okay?
So pretty much
But rooms
anywhere.
1 through 5 have special ports just for telestroke.
And it's extra, so
It is extra. It has a pink dot on it. Eventually, it's going to have a thing that says telemedicine only, and it'll be pink. We've chosen to go pink for everything, including the cable that will be on the back of the machine when it comes. We've ordered a pink cable. Okay? The 3 main things that we need immediately is last known well, their finger stick blood sugar, and then their platelets. And so we're probably going to change our order sets a little bit to take out the differential, because there is a CBC that we can get that just has the top part. Because when we call the neurologist, when our doc calls the neurologist, those are the 3 things they want to know. And we've been kind of remiss about getting a blood sugar right away if they come in by car. And sometimes it's been an hour before we've gotten a blood sugar. So the idea now is those are the 3 things we need. We need a blood sugar, we need to know when they're last known well, and their platelets. And Dr. Barger said this morning, he was here to talk to the docs, that even if we don't have the platelets, and even if they're on a anticoagulant and we don't know their INR yet, they may still qualify for TPA. So the facilitator, we've decided, is going to be the primary nurse for that patient. So if you're in MedSurg or CCU, you would be the one that would be the facilitator for helping the doc. If you're in the ED, it'll be the ED RN that has that patient. So, and then all the other nurses will be your slaves. They will be your go-to people to help you. But you will be the one that will actually be facilitating. These stroke binders that Susan's going to go over, you're going to be able to find them in rooms 1 through 5 in the ED, in CCU, in MedSurg, and on the cart. And they have everything that you need to do a stroke patient from start to finish. The stroke cart works unplugged for 4 hours, as long as the battery's been plugged in. So it can be used in the rooms without being plugged in, without having another thing to trip on. And whoever is working with that patient will be responsible for restocking the binder, and we'll have all the materials. And the last thing is that the pharmacy is the one that does the dosing for the TPA. All they need to know is their weight, and they can, when our doc pulls the trigger and says we're going to do TPA, the pharmacy will figure the dose for you. Their standard of work now, and it used to be some of them would just bring you the bag and you'd have to figure out how much to give them for 10% for the first dose and then the other 90%. They've changed their standard of work. They're going to bring you a syringe with the bolus dose, and they're going to bring the bag with the rest of the dose. So you can give the bolus, be assured that that's the 10%, and then hang the bag for the rest of it. So Susan's going to go over the new notebook.
So these binders are divided into 3 parts. There's nurse-driven, physician-driven, and patient education. What you'll do when you get this binder is you'll open it up, and right away you'll see the revised checklist that follows the patient to Virginia Mason or to the floor or to CCU if you're in the ER, or just to Virginia Mason if the stroke happens elsewhere in the hospital. And you can see on the top there what it has in it. And it's been revised to flow a little bit better. And what you can do to make it easier, if you'd like, is just flip this open, pop this binder open, take the nurse driven out, take the physician driven, and you need to be sure that that gets to the physician. That's one reason we divided it like that. So you've got the check sheet, the NPO sheet. We do have a paper stroke scale, especially for use on the CCU and the floor. You have your pictures, words to read, your swallow screen, and this is all the nursing driven. There's also a little scripting part in case you need to know how to explain to the patient about Telestroke. It's also a reference because there's so many new antiplatelet drugs and anticoagulants, in case you don't know whether you have a patient on one of those. Okay, so the physician-driven part will be the checklist of the dose of the TPA and the exclusion sheet should be in here. Inclusion, exclusion. Yes. For the criteria. It should be in there that it kind of flips up with the rest of them. So these are the two sheets the physician is going to need. You probably need to be proactive in making sure those get filled out. And the consent for TPA. And there's a nice little guide for patients and families to look at that shows the actual risks of TPA. There will be the extended booklet that we're used to using, those small orange booklets, still in the ED rooms and wherever you keep them in CCU and med-surg. Also on the front of these binders is kind of nice where you have this little process flow with little pictures, and it's an easy reference to tell you what 3 things are needed on the initial assessment: last known well, the finger stick blood sugar, and a platelet count. And these are things the physician is going to need back in addition to your initial vital signs. They can call the neurologist with these. Call through Linda Mason, consultation, stroke.
So are these taking the place of our stroke packets in the ER then?
Yeah. And one reason we did this is because it was noted that people were having to go to the room to respond to a stroke alert, then go back out to the nurse's station, find the packet, bring it back in the room, and these will be already in there.
And then on the back.
Oh, yes. And this will tell you again the 3 different areas: the nurse-driven, physician-driven, patient education.
And we'll make sure the drawers are filled before Monday. I'm going to come in on the weekend and fill the drawers next weekend.
Are there more than, are you planning to have this in the room with the stroke patient? So if there's more than one stroke patient, do you have more than one binder?
They'll be in every.
They'll be in rooms 1 through 5. There'll be 1 in CCU, 1 on med-surg, and 1 on top of the stroke cart. So we have 8, and if we find that we need more, we'll make more.
And that's it. Easy.
Med-surg charting isn't going to change. However, there is on your procedure code page, there is now a Telestroke consult over on the right-hand side under the physician side, where you put chest tubes and that type of thing. It's just a check mark, and that's how it will get charged. The patient gets a $44 facility charge. It's going to take us a long time to pay for that machine at $44. And then the neurologist will be sending a bill. Virginia Mason will be sending a bill, both of which are reimbursed by Medicare. And so if you've got an 84-year-old patient who's like doesn't want to take an ambulance because Medicare's not going to pay for it, they will pay for both the facilitation fee and the neurologist fee because we are critical access, and they'll pay it 100%. So. Okay, so we have built in both medical orders and charting. Under the medical orders, there's two new things. Under the standard orders, under stroke and ED stroke, so we have acute greater than 6 hours, and then stroke acute. We're going to change it to greater than 6 hours, less than 6 hours. Also the telestroke implementation, but what we added to both stroke order sets, and it's the same on the nursing side, so if we have stroke acute lytic, what we added was consider telestroke implementation order set. Okay, that's on every single patient with possible stroke. Then what we did was a telestroke implementation that says, make sure you got a finger stick, make sure you got a platelet count, make sure you got last well known, and then take the cart to the room and set it up for the Virginia Mason neurologist. We have to have an order in order to be able to charge for it, and we, so that's why we went that route.
So it does take just a few
And then when you go to clinical notes, all you have to do is start typing telestroke, hit enter. It has the carts in the room, connected to data port, turned on, connected to Virginia Mason, yes.
Whatever port.
Patient teaching, the teaching was done with patient family, the patient couldn't do it, so you did it with the family. Did it, the patient wasn't alert, so you did it. We have 7 neurologists that will be doing this program through Virginia Mason. Their names are here. And so you saw Dr. Stilova on the camera that he showed. And then patient and family either understand the visit with the neurologist or they have continued questions, and we told our ER doc, okay, to answer the questions. That's all there is to it. So you've got your orders, and you have the other thing that we haven't always remembered to do was the finger stick. It's under FSBS. You hit enter. If the RN did it, it was 35. Well, maybe they're not having a stroke, maybe they're having a low blood sugar. Or it's 650, or the patient's drunk, or whatever. You won't run into that, but we might. So, the other thing I wanted to just touch on briefly was on the left and this is where the CCU nurse will come in, making sure that we are getting times on here, because we probably won't be at the computer, but we can write the time that they got back from CT. We can write the times that all of this happened and go back later and chart. So like at 2:30 in the morning when Noreen's getting ready to leave,
and ultimately we may
she may, at least we've got it on paper as to, it's kind of like our code blue sheet, then you can go back and chart everything in Empower. So one of the things that we're going to ask the CCU people to do is take ownership to this sheet. The left-hand side is before TPA. If the patient gets to have TPA, then the right-hand side will come into effect. So, and this, we're getting a barcode on it, so it will be a part of the patient record. So when this follows the patient, say we decide to keep the patient, and Nora was talking a lot today about we could keep some of these stroke patients even that we give TPA to. She and Dr. Barcher were talking this morning. Dr. Kirschmer?
Yeah.
And so then on the back of this, we'll have your 24-hour vital signs. It's just a checklist. We did them every 15 minutes for 8, and we did them every 30 minutes, and we did them every hour. So it's going to be the 24 hours worth of vital signs will be on the back. So there you go.
Question, like what if it's a TIA and their symptoms are already starting to resolve maybe by the time they get to the ED? Are you still doing the telestroke in that circumstance?
We might,
Or is
if the doctor, the ER doctor and the neurologist want to have want the neurologist, say we're gonna discharge the patient, but they're gonna go to Virginia Mason the next day. The whole idea is that we're doing this warm handoff, that they have a chance to meet somebody, the family has a chance to meet somebody from Virginia Mason. So we might on that TIA, especially because we're going to probably be admitting our TIA patients because we all know they can extend within 30 days even. So, but then the most critical time is that first 24 hours. So they may still do the telestroke. Yep.
I'm going to show you about the cart. We're going to kind of go over this here and see if you can help, and we'll just kind of go over it so that it's not too scary. So it comes up.
So you can pick whoever it was, and then did this patient
This data port and cord are the key things. It needs internet access. It's proven to not work very well with wireless. The signal's not very good, and the clarity of the picture hasn't been as good, and is a little more intermittent. So no one has recommended that we or you or anybody go wireless on this particular setup. So that's why we're doing all the hard Ethernet connections throughout the hospital here. So once this is, it doesn't matter, you can turn it on and plug it in, or plug it in or turn it on. It's really pretty durable. It doesn't really care what you do. The only thing you want to check is that these little lights down here are all green. Of course, they're well hidden underneath the speaker/microphone. But the little green lights say the battery's charged or is in the process of charging. If it's not there, then the battery may be dead. So that would mean not only do you need to put the data port in the wall, the other need to plug it in. And there's just a 3-prong cord in the back that will need to be plugged into the wall. Turning it on. The little on-off button is well hidden under here, and you just press and hold till it beeps.
So if the CCU nurse comes,
and then there's a little delay while the camera kind of does its thing, the monitor does its thing, and it tries to kind of get booted up here, as any computer would do.
Just like we do with Code Blues. We can do that. Then if the patient is going to get TPA,
key component
this goes into
is this
effect,
little remote here.
and it's got your vital signs the first 2
when this
hours
comes up,
and then on the back
you'll need to use the remote
rest of the 24 hours.
to scroll through some options. Now, if you're having any trouble with this thing,
right now we'll scan it on.
certainly Susan or Linda or some other of your staff, Cody, know some stuff about this. Keith Graham in your IT department has been, we've been working together, and he is able to log in remotely and adjust some stuff. So it says it's lost the IP setting or something that you don't understand, it's just not coming up. He can help you with that, okay? So you'll see when this comes up, you're going to have a little green line around this little 4-button thing. If you just hit the down, it will take the little green thing down to Telestroke. Okay? KVH Telestroke 1, that's the name of your cart. We didn't call it Betty or anything kind of cool. And then you're going to hit enter or OK, and it's going to say join my room, and you're going to hit enter again.
And manual blood pressure.
Oh, look. There you are. So this is what you should see initially. Now, there is something, the second other thing you want to remember is self-view. And you're self-viewing right now. Since I'm not logged into here, your other option is to see the doctor and self-view, or self-view alone, or the doctor alone. But if I hit self-view right now, what you're going to get is a black screen.
It has everything in there.
The doctor hasn't logged in yet, so he or she isn't appearing here. So if this boots up as a black screen, you're going to want to check 2 things. One, do I need to reset the self-view? Or 2, is the monitor itself turned off? Well, obviously you've got some little doodads there, so it says the monitor's on, so this will be self-view. That comes back in. You can set this up and leave it. So if they say, we're going to do a telestroke intervention, I want you to bring a telestroke machine in, Dr. Frick or somebody says, go ahead and put the telestroke.
And if we,
This is in the ED, obviously. So you bring it in, you turn it on, you plug it in, and up this comes. This will all be written out, how to do this stuff. So if you forget or if there's some problems, then you'll refer to that manual and do that. So now you're waiting for the doctor to log in. And they'll have laptops provided by us, along with whatever they have at home and whatever they have at work. So in the evening time, they may need to get to a quiet spot. We advise them not to have the screaming kid in the background if they're at home and some of those things. If they're at a restaurant, we'd like them to go someplace different with their laptop and set it up. But they'll be able to access Verizon wireless, and they'll be able to log in pretty much wherever they are. So that's what they'll do. So that may take a few minutes is all I'm saying. So once you guys get going, then they can have the other thing I've seen, of course, is that you have no idea that it's going to be a telestroke thing. And by that time, the doctor's already logged in because he's talked to the two doctors and they said, oh, stuff. So he logs in from home very quickly, and then you might walk into the room and boot this up. And as soon as this picture comes up, you're going to see the doctor. So let me log in over here as if I were the doctor. The self view again is going to give you this little picture here. We've had patients ask, what's the doctor seeing? And so we can, this is either on or off or on. And so we can say, okay, here's what the doctor is seeing when you're talking to them. I don't know why they want to know that, but I guess they want to make sure that their privacy is not being violated or whatever. So this mutes it.
Thank you, thank you.
Your
This counts as 1 hour for those of you that, about an hour of the stroke education on November 12th. We're going to have
That's
2 3-hour presentations. They'll be exactly the same.
Okay, so
There'll be
you'd
one
be
in the
cut
morning,
off.
one in the afternoon.
You would still hear
For the other 3 hours that
physician
you need, they will also be on
talking.
videotape. Because we
Okay?
have to have 4 hours.
He or she can mute it on their
every year.
end so
And
that,
Virginia
you
Mason's coming
you
back.
can't see. But if you hit this button, what he's going to see is,
People around our hospital are going to do the 3rd hour.
and that's all
of
that will go on.
And
So
then at
you guys
the
can have a
end,
private
we'll
conversation
stay.
on your end. He can have a private conversation on his end
From 12:30 to 1:30.
when you
And then
mute
2
it.
o'clock
And it's
we'll resume.
flashing
So
when
it'll
it's
be
muted,
9
correct?
till noon.
Correct. When this is
12:30 to
muted,
1:30, and then
it will blink
2 to
on and off.
on the 12th. Can't be here on
And
the
to
12th.
shut it off completely,
It's
you
not a
just
problem.
press and
We will
hold.
have it videotaped, that's why we hired Jerry.
Till it goes off, till there's no light.
Because Marla
So
is really
they're going to
pushing
tether
for
this
our
to the machine
nurse to double staff
with
that
some
they were
kind of
used to.
cord,
I don't know that I'll have that.
chain or something.
And then the position is marked in the ER rooms on the ceiling.
So anyway.
It's
so
just
they-
a general guide to, it's like a piece of pink tape on the ceiling.
Plus the end of life.
And it's just a general guide. You may have to move it forward, backward, because you would push it to where, you can see the,
That counts.
like now you could see my head in there. But in the ED rooms, we tested it out, and in that position, where the stretchers are, normally, you can see the entire patient. You can see from their head to their toe on the stretcher. And the CCU and med-surg rooms would have to be worked out. But it is in the ED, we've tested all the big rooms. And it's only going to be ED 1 through 5 that we use them in. The other room's just too small.
So as far as what
We'll go over.
he's seeing, he can really zoom in. So if he wants to do an eye exam of sorts, to check out ocular movement, those sorts of things,
So the first
it's
one.
very easy for him to do that. So you get the card in, set it up, turn it on. Then you're going to act as sort of a telefacilitator, and that's going to be,
If it's an ED, the CCU.
I don't know how to describe it except as a facilitator. You're going to do nurse stuff, as we all do. Patient care is always kind of a primary thing. But the neurologist, when he or she comes on, is expected to sort of introduce themselves. You can help facilitate that, making sure that he or she knows who's in the room. They get a bit of a stilted view here. They can certainly pan left and right to see everybody in the room, but if Mr. Smith is somewhere out of the camera, they do like to know who's in the room. So, Mrs. Smith's husband's over here, her daughter and son are over here, and so they can either step out and go like this, or he can pan back and forth to see them. But at least everybody knows who's in the room. It's important to have everybody aware of what's going on. And then you may or may not have finished a stroke scale on this patient. The doctor's going to walk you through. He or she's going to want to do his own stroke scale for that patient. And again, as I was telling the other group, it's going to be probably abbreviated. So they won't need all the information. They can always circle back to finish up their stroke scale if they need to. So, Susan, you want to?
Yeah, and well, in that stroke scale, one thing to bear in mind is the entire, you don't do the whole complete stroke scale and then call the neurologist. This is kind of all simultaneously happening. And then if your neurologist makes a decision really quickly, doesn't do any more than a really quick stroke scale, says yes, we're going to do TPA, then the nurse needs to somehow or another fit in the rest of the stroke scale.
And the neurologist may do an abbreviated stroke scale, like I was saying, and then he will have to fit in the remainder of his stroke scale if he wishes to do that. So it's really about the decision to give or not to give the TPA. The lytic is the big thing that they're going for and trying to get that on board as quickly as possible. So when the physician's on, he's going to talk to the patient, I hope. Sometimes they come on and they talk to you. They go, hey, could you? And then I always say, hey, you can ask the patient. She's doing just fine. She just has this little droop and a little bit of slurred speech. She understands you. So then the physician looks at the patient, which is really what we want. And I say, please give me your name. And then they will start going through that thing. So sometimes a little pleasant, tactful redirection is okay without having to involve you with each of their requests. But they will get to a point where they want to use you as their hands. And so at that point, also they're going to be talking to you as if you had not had any stroke training at all, as if you've never done a neurologic exam. If you show that you have, then that's great, but we want them to be able to instruct you to do what it is they want to see. So, with finger nose, chin to heel, grips, drift, all those things, we want them to be pretty straightforward. And then there'll be some subjective things that you may have to intervene. So if they're saying they may not hear, they may not see, frequently say, can you move the cart so I can see a little bit better? Fine, no problem. Otherwise, they might say, did the patient feel when you were touching them on the left side? That's your input. Yes, they did. And so that's fine. So not necessarily an interpretation of anything, but really just an objective finding that they did that. So that's reasonable to talk to them. And then the rest of the time he should be kind of guiding the patient. Mrs. Smith, we're going to have Jerry here hold his finger out in front of you, and I want you to touch his finger with your left hand, and I want you to touch your nose. We're hoping that's what the docs will do, but you guys will be able to assist to sort of say, okay, I got it, okay, and then you can sit down in the bed, Mrs. Smith, and hold my finger, how much you tie, and go through the whole kind of thing for them to see that. So we want them to be present in the room as if they were actually in the room. And one of the ways they can do that is to actually talk to the patient and the family. The interventions that I've been involved with, they may start out kind of avoiding talking to the patient and family, but by the end of it, everybody's involved, everybody's over here, and they're asking questions to the doctor and all sorts of things are going on, and so people get really involved pretty quickly, and I think feel kind of left out if they're not part of the picture or not doing the thing. It's actually fun. It's really very fun. Plus, it's a good learning experience, I've found, because it's nice to talk to the neurologist and have them go over stuff. The other thing that, well, I'm thinking of that you might be involved with is out of that stroke packet, the pictures. So they're not going to, they're going to say, okay, let's do the pictures. Can you hold the pictures up for Mrs. Smith? So you're going to have to go, just like you would normally. Okay, I want you to describe what's going on in this picture, Mrs. Smith. What's happening here? What's going? However you would normally do that. They're not going to be able to see, so they may say, how's she doing? She got it right? And actually, they know the pictures backwards and forwards a million times, and so they'll know. But that would be the only other thing. Especially if they have a quiet, slurred speech of a stroke patient, they might not hear so well, although that microphone is really good. But anyway, that would be the only other time that you might be asked to kind of get involved with these things. Please read this. Did she get it right? Yeah, she got it right. And so you can kind of help out in that as far as interpreting. And then the other thing is this picture at the back. And that's 100 little guys. And so they might say, okay, can you show this to the family? And here's the risk factors involved with TPA. These people here aren't going to have any changes at all. These people here are going to basically get better, a little better. These people are going to have complete resolution of their symptoms. So complete resolution, get better, but not fixed. No change at all from where you are now. And then these 6 down here didn't do so well. So 3 of them may have some untoward effects. 2 of them are going to have a hemorrhage that may do okay, and 1's going to have a hemorrhage that isn't going to do good at all. So we use that to sort of describe. They all have copies, so they all know exactly, they'll be able to go over that. So lastly, Susan, chime in anytime.
Okay. There's one of the differences too, especially for house supervisors to know, is that now the goal is, it may not always be possible, for a CCU nurse to also respond. Because there's going to be, things should be moving a lot faster than they even have before, and especially if there's one available at night, we realize there may not be, but that will help when there's only 2 nurses in the ED. And in the early morning too, as far as they can function as that extra set of hands in there, especially if there's a lot of other things going on in the department. And the other thing is that wasn't mentioned before, the procedure on the floor and in CCU is they're going to be calling stroke alerts, and the goal is for everything to happen exactly as fast as it does when it happens in the ER. The ED nurse will be assigned whoever's going to respond to stroke alert on the floor, in addition to the CCU nurse or whoever's going to be assigned to respond to ED if they need it. So the ED nurse will bring the telestroke cart down with them, but they're not going to be staying through the whole facilitation because that's going to be the primary nurse. So the house supervisor is who we've designated as being the one that makes sure it gets back. And those were the other things that were a little bit different.
So obviously it's on wheels. So that's the up-down. And I think you guys have to lower it to fit into its location down there in the ED. And then you can bring it back up. And you may need to lower it or readjust that a bit in order to see the patient. So, remote control. We'll go through this one more time. So press and hold to shut it off. Plug the data cable into the wall outlet dedicated for the data cable. There is a 4-hour battery life on this unit. Please be sure to check that the green lights are on down here. If those lights are not all green, then go ahead and plug the telecart into a wall outlet to make sure that it has enough power to complete the telestroke intervention. Then you're going to go ahead over here and you're going to touch this one button here, the on-off button, and hold it in till it beeps. Once it beeps, the telecart should be ready to boot up. So that'll take just a few seconds here for it to run through its boot up process, and then we'll have to use the remote control to finish it off. The critical buttons that you're going to see on the remote are the up and down, especially the down, these four little left, right, up, down buttons, and the OK button. The other one that you will be using is the self view, and that will switch between viewing just yourselves or having a little picture in the lower right corner. So as the machine's booted up, we can go over and take a look at that right now, and I'll show you how to use the remote. After the machine's been turned on and gone through its boot up process, you should get to this screen here. If you haven't gotten to this screen, then you may need to unplug the machine again from the data port, shut it off, and reboot the whole thing and start over. Once you get to this screen, you're going to use the remote. And as you can see, there's a little green highlight around this search area up here. You're going to go down from that by pushing the down button over here, and it's going to highlight KVH Telestroke 1, which is the name of this cart. Once you've done that, you're going to hit OK, and it will ask you to join my room, and you're going to hit OK again. And then you should get a picture either of the physician, who may already be logged in, or you're going to get a picture of yourselves in your room. The patient would be on a stretcher out here, and that would all be set up. So next we can show you what happens when the physician logs in. So at this point, I've logged in as the physician, as the stroke neurologist, and I can see the patient through my camera at my end, and you can see a headshot of me. And at that lower right corner, you'll also see a little picture of what's going on in the room. Several of our patients have asked if they could see what the physician was seeing. I think there's a better comfort level with being able to see as the physician pans, zooms, tilts, and does the various things with the camera. They want to be sure that, I think that their privacy is protected and that everything's okay. But this would be the view that you would see normally when the machine's up and running and the provider is logged in. This is the speaker microphone combination. It's mounted on here, and it comes on automatically when you boot up the whole telecart. What you'll need to know is that this is the volume control on this right side as you're looking at it. So here you can see me. As if the volume control goes up, you'll be able to hear what it sounds like for the patient, and the provider at the other end will be able to tell you how the sound is coming through on his or her end, and that goes down. The other thing that this offers you is the ability to mute your end. So hitting that button once, the blue light will begin flashing. When it's flashing, it means that you've muted yourself against the provider. So now the provider is not going to hear anything coming out of the room. To shut the mute off, just hit it again. And then if you wanted to shut the whole microphone speaker system off, you would push in and just hold it in until it stops beeping. There, so there it's off. One punch, it should come back on, and now you're up and running again. These two buttons on the left side, as you're looking at it here, are for some different line inputs that we don't have. You can ignore those. Really, the only ones you care about are volume up, volume down, and this mute on/off button right there. So when it's ready, it's time for you to discontinue the telestroke intervention, and you want to shut the computer down. Be sure you tell everyone that you're about to do that, so that the family and the patient, they all know that you're ending the intervention, that the doc at the other end knows that you're going to disconnect, and that everybody's going to disconnect. And so the way that you do that is that you push and hold this button just like you turned it on. You'll get a beep, screen will go blank, you're ready to unplug it from the wall and put it away back in the ED.